Welcome to the University of Texas School of Dentistry at Houston Continuing Dental Education Program. I'm Dr. Deborah Franklin, and I'm the course director for the course Smoking Cessation for the Dental Professional. I'm an associate professor in the Department of General Practice and Dental Public Health. I also have a master's degree in clinical psychology and am licensed as a professional counselor. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. This presentation contains information on the health consequences of smoking and exposure to secondhand smoke, the addiction and habit components of smoking, pharmacological aids to smoking cessation, and resources for smoking cessation. This presentation also references the 10 key guidelines from the 2008 update to the 2000 Public Health Service Clinical Practice Guidelines on treating tobacco use and dependence, and the health consequences of smoking, 50 Years of Progress, a report of the Surgeon General. After completing this section, the participant should be able to describe the relationship between diseases, death, and smoking in the United States. Discuss the decrease in smoking prevalence from 2005 to 2012. List 6 evidence-based facts supported by the health consequences of smoking, 50 Years of Progress, a report of the Surgeon General. Describe the mechanism, advantages, and disadvantages of the electronic cigarette. Describe the effects of nicotine and the symptoms of nicotine withdrawal. Describe how behavioral factors contribute to a smoking habit and smoking cessation. List the 10 key guidelines from the 2008 update to the Public Health Service Clinical Practice Guidelines on treating tobacco use and dependence. Describe principles and violations of motivational interviewing. List online resources for smoking cessation. List non-prescription pharmacological aids to smoking cessation. List prescription-only pharmacological aids to smoking cessation. Tobacco use is the leading preventable cause of death in the United States. Cigarette smoking is accountable for more than 480,000 deaths, or 1 of every 5 deaths each year in the United States. Each year, smoking kills more people than AIDS, alcohol, drug abuse, car crashes, murders, suicides, and fires combined. The consequences of smoking to oral health include oral cancer, leukoplakia, stained teeth, increased risk of periodontal disease, halitosis, and delayed wound healing. Cigarette smoking causes about 1 of every 5 deaths in the United States each year. Cigarette smoking is estimated to cause more than 480,000 deaths annually, 278,544 deaths annually among men, and 201,773 deaths annually among women. Cigarette use causes premature death. Life expectancy for smokers is at least 10 years shorter than for non-smokers. Quitting smoking before the age of 40 reduces the risk of dying from smoking-related disease by about 90%. Secondhand smoke is the combination of smoke from the burning end of a cigarette and the smoke breathed out by smokers. Secondhand smoke contains approximately 70 carcinogenic chemicals. There is no risk-free level of exposure to secondhand smoke. Exposure to secondhand smoke causes nearly 42,000 deaths each year in the United States. Secondhand smoke causes 7,333 annual deaths from lung cancer and 33,951 annual deaths from heart disease. The number of U.S. adults who smoke cigarettes fell to 18.1% in 2012. During 2005 to 2012, the percentage of smokers who quit increased from 50.7% to 55%. During the same period, the proportion of daily smokers who smoked greater than or equal to 30 cigarettes per day also declined. These statistics may be partly due to the use of tobacco products other than cigarettes, such as hookah, bidis, snus, etc. The decline in overall smoking prevalence from 20.9% in 2005 to 18.1% in 2012 likely reflects the success of tobacco control efforts across the United States. Published in 2014, The Health Consequences of Smoking, 50 Years of Progress, a report of the Surgeon General, is the 32nd tobacco-related Surgeon General's report issued since 1964. It highlights 50 years of progress in tobacco control and prevention and presents new data on the health consequences of smoking. Scientific evidence contained in this report supports the facts on the following 6 slides. The century-long epidemic of cigarette smoking has caused an enormous, avoidable public health catastrophe in the United States. Since the first Surgeon General's report on smoking and health was published 50 years ago, more than 20 million Americans have died because of smoking. If current rates continue, 5.6 million Americans younger than 18 years of age who are alive today are projected to die prematurely from smoking-related disease. The tobacco epidemic was initiated and has been sustained by the tobacco industry, which deliberately misled the public about the risks of smoking cigarettes. Smoking remains the single largest cause of preventable disease and death in the United States. Nearly 500,000 Americans die prematurely from smoking each year. More than 16 million Americans suffer from a disease caused by smoking. Smokers suffer more health problems and disability due to their smoking and ultimately lose more than 10 years from their lifespan. The estimated economic costs attributable to smoking and exposure to tobacco smoke now approach $300 billion annually. Since the first Surgeon General's report in 1964, evidence has linked smoking to diseases of nearly all organs of the body. In the United States, smoking causes 87% of lung cancer deaths, 32% of coronary heart disease deaths, and 79% of all cases of COPD. 1 out of 3 cancer deaths is caused by smoking. Smoking causes colorectal and liver cancer It increases the failure rate of treatment for all cancers. In addition to causing multiple other serious diseases, cigarette smoking diminishes overall health status, impairs immune function, and reduces quality of life. Smokers today have a greater risk of developing lung cancer than did smokers in 1964. Smokers smoke fewer cigarettes today than 50 years ago, but they are at higher risk of developing lung cancer. Changes in the design and composition of cigarettes since the 1950s have increased the risk of adenocarcinoma of the lung. Ventilated filters may have contributed to higher risks of lung cancer by enabling smokers to inhale more vigorously. At least 70 of the chemicals in cigarette smoke are known carcinogens. Levels of some of these chemicals have increased as manufacturing processes have changed. For the first time, women are as likely to die as men from many diseases caused by smoking. Women's disease risks from smoking have risen sharply over the last 50 years and are now equal to men's for lung cancer, COPD, and cardiovascular diseases. The number of women dying from COPD now exceeds the number of men. Between 1959 and 2010, lung cancer risks for smokers rose dramatically. Among female smokers, risk increased tenfold. Among male smokers, risk doubled. Proven tobacco control strategies, along with enhanced strategies to eliminate the use of cigarettes and other tobacco products, will help us achieve a society free of tobacco-related death and disease. The goal of ending tobacco-related death and disease requires additional action. Evidence-based tobacco control interventions that are effective continue to be underused. What we know works to prevent smoking initiation and promote quitting includes hard-hitting media campaigns, tobacco excise taxes at sufficiently high rates to deter youth smoking and promote quitting, easy-to-access cessation treatment and promotion of cessation treatment in clinical settings, smoke-free policies, and comprehensive statewide tobacco control programs. What about the e-cigarette? Using the e-cigarette is also referred to as vaping. What are e-cigarettes? E-cigarettes are a capsule of liquid nicotine solution heated by an atomizer powered by a rechargeable battery. The nicotine solution is converted to a vapor and inhaled. This simulates the action of smoking. The components of an e-cigarette are the cartridge, atomizer, battery, and light. The advantages of the e-cigarette are that it is odorless. It provides the same hand-to-mouth motion that smoking does. It is accepted in some social situations. Users claim they are as satisfying as tobacco cigarettes, and they ease nicotine withdrawal symptoms. A major disadvantage of the e-cigarette is that it is not FDA approved for smoking cessation. Another is that the nicotine content is unreliable. Toxic ingredients detected by FDA analysis include diethylene glycol and known carcinogens. Companies are marketing their products as tools to help people quit, but there are no long-term clinical studies showing the products are an effective treatment for nicotine dependence. The health benefits of quitting smoking are many. After 20 minutes, blood pressure decreases, pulse rate drops, Body temperature of hands and feet increases. After 8 hours, the carbon monoxide level in the blood drops to normal, and the oxygen level in the blood increases to normal. After 24 hours, the chance of heart attack decreases. After 48 hours, nerve endings start to regrow, and the ability to smell and taste is enhanced. After 2 weeks to 3 months, circulation improves, walking becomes easier, and lung function increases. After 1 to 9 months, coughing, sinus congestion, fatigue, and shortness of breath decreases. Cilia regrow in lungs, increasing ability to clean the lungs and reduce infection. After 1 year, excess risk of coronary disease is decreased to half that of a smoker. After 10 years, the risk of lung cancer death is about half that of a smoker's. And after 15 years, the risk of heart disease is the same as a non-smoker's. Nicotine is the drug in tobacco products that produces dependence. Most smokers are dependent on nicotine. Research suggests that nicotine may be as addictive as heroin, cocaine, or alcohol. Quitting smoking is difficult and may require several attempts. Users often return to smoking because of withdrawal symptoms, stress, and weight gain. Addiction is the compulsive use of a substance regardless of negative consequences. Is nicotine addictive? Yes. Most smokers use tobacco regularly because they are addicted to nicotine. Most smokers identify tobacco use as harmful and express a desire to reduce or stop using it. Among current U.S. adult cigarette smokers, 68.8% report that they want to quit completely. Starting in 2002, the number of former smokers exceeds the number of current smokers. Nicotine activates multiple biological pathways through which smoking increases risk for disease. Nicotine exposure during fetal development has lasting and adverse consequences for brain development. Nicotine exposure during adolescence may have lasting adverse consequences for brain development also. How does nicotine work? Nicotine activates reward pathways in the brain circuitry that regulates feelings of pleasure. Nicotine increases levels of dopamine in these reward circuits. This reaction is thought to underlie the pleasurable sensations experienced by many smokers. Cigarette smoking produces a rapid distribution of nicotine to the brain, with drug levels peaking within 10 seconds of inhalation. The pleasurable effects are short-lasting, which causes the smoker to continue smoking to maintain pleasurable effects and prevent withdrawal. Nicotine withdrawal symptoms include craving tobacco, lightheadedness, irritability, craving, depression, anxiety, poor concentration, sleep disturbance, increased appetite. Symptoms may begin within a few hours after the last cigarette. Symptoms peak within the first few days of smoking cessation. A habit is a recurrent, often unconscious pattern of behavior that is acquired through frequent repetition. The feel, smell, and sight of a cigarette and the ritual of obtaining, handling, lighting, and smoking the cigarette are all associated with the pleasurable effects of smoking and can make withdrawal or craving worse. Behavioral therapies can help smokers identify environmental triggers of craving so they can employ strategies to prevent them. Cigarette use is a habit. Smoking becomes automatic. The person may not consciously think about smoking or even remember lighting the cigarette. Cigarettes may be used to cope with stress or deal with uncomfortable situations. Psychological reasons for smoking have been stated as smoking relaxes me. Smoking stimulates my creativity. Cigarettes make good times even better. There are many smoking triggers. Some include smoking when I'm happy, I'm at a party, I'm depressed, I'm nervous or stressed, things aren't going my way, I see someone else having a smoke, I get in the car, I'm having a cup of coffee, I first wake up in the morning, or I'm bored. What do you do when a patient asks you, "Can you help me stop smoking?" Quitting is a two-step process. The patient must overcome the physical addiction to nicotine and must also break the smoking habit. The following information is excerpted from Treating Tobacco Use and Independence, the 2008 update to the 2000 Public Health Service Clinical Practice Guidelines. There are 10 key guideline recommendations. Tobacco dependence is a chronic disease that often requires repeated intervention and multiple attempts to quit. Identify and document tobacco use status with every patient and treat every tobacco user seen. Tobacco dependence treatments are effective across a broad range of populations. Brief tobacco dependence treatment is effective, and every patient who uses tobacco should be offered at least brief treatment. Treatments involving person-to-person contact are consistently effective, and their effectiveness increases with treatment intensity. Numerous effective pharmacotherapies are available and should be used with all patients attempting to quit smoking, except in the presence of contraindications. Counseling and medication are effective when used by themselves for treating tobacco dependence. The combination of counseling and medication is more effective than either alone. Telephone quitline counseling is effective with diverse populations and has broad reach. If a tobacco user is currently unwilling to make a quit attempt, clinicians should use motivational treatments to be effective in increasing future quit attempts. Tobacco dependence treatments are both clinically effective and highly cost-effective relative to interventions for other clinical disorders. Providing insurance coverage for these treatments increases quit rates. There is no ideal intervention that will turn all smokers into permanent non-smokers. A 3-minute intervention is recommended for all patients who smoke. The 5 A's of a 3-minute intervention are ask about tobacco use, advise tobacco users to quit, assess their readiness to quit, assist with a quit attempt or increase their readiness to quit, and then arrange follow-up care. Ask. Ask about tobacco use. Ask every patient at every visit. Ask about their current level of use and the type of tobacco they use. Ask about their age at first use. Ask about their maximum level of use. Ask about the time from waking to their first cigarette or dip or other tobacco use. Ask about their success in previous quit attempts. Ask about their environment. Advise the patient to quit. Stress the importance of quitting. Personalize the advice to your patient. Deliver a clear message and deliver a strong message. Assess willingness to make quit attempt now. And by now we mean within the next 30 days. Assess the patient's readiness to quit, the patient's motivation to quit, and their confidence about quitting. Resistance to change is normal. Motivation to change is a personal process. People resist change that is forced upon them. People support what they've helped to create. The responsibility for change lies with the individual, but people are often ambivalent about change. Principles of motivational interviewing include expressing empathy, helping patients identify inconsistencies between their goals and current behavior. The patient should present the argument for change. Avoid argument and direct confrontation. Adjust to the patient's resistance rather than directly opposing it. Support the patient's self-efficacy and optimism. The patient needs to believe that change is possible and that he or she can choose and carry out personal change. Violations of motivational interviewing include assuming a person has a problem and needs to change, offering direct advice or prescribing solutions without the patient's input, using an expert position, doing most of the talking, imposing a diagnostic label, and behaving in a punitive or coercive manner. To summarize, be with the patient in their challenges and resistance. Learn by asking open-ended questions. Let the patient know you understand through reflection and summaries. Allow and encourage autonomy. The fourth A of a 3-minute intervention is assist. Aid the patient in quitting by providing counseling and medication. Set a quit date within 2 weeks. Tell family and friends that you are quitting for support. Anticipate challenges to the quit attempt. And remove all tobacco products and alcohol from the environment. The dental professional can provide practical counseling such as problem solving, can provide a supportive clinical environment while encouraging the patient in his or her quit attempt, and can provide supplementary materials including information on quit lines. The fifth A of a 3-minute intervention is arrange. Ensure follow-up contact. You can do in-office follow-up, the patient can follow up with quit lines, or the patient can follow up with individual counseling. This is a list of online resources for patients who have access to the internet. Nicotine replacement therapy is used frequently in smoking cessation. The first pharmacological treatments approved by the FDA for use in smoking cessation therapy are the nicotine replacements. They provide users with lower overall nicotine levels than they receive with tobacco. They do not contain the carcinogens associated with tobacco smoke. They have little abuse potential since they do not produce the pleasurable effects of tobacco products. And they are used in conjunction with behavioral support to relieve nicotine withdrawal symptoms. Non-prescription nicotine replacement therapy items include the nicotine patch, nicotine gum, and nicotine lozenge. Prescription-only nicotine replacement therapy include nicotine nasal spray and nicotine inhaler. Drugs that are used to aid in smoking cessation include bupropion and varenicline. This completes the presentation of smoking cessation for the dental professional. It is time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 90% is necessary. Upon a successful completion of this exam, you will be visually informed that you have passed. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to review this section again. Good luck on the exam.